session. So it was our privilege to have you with us for the last 18 sessions. And we have gone through many symptoms and end of life care, ethics, communication, etc. And this is another important topic. Uh, Opioids are not uniformly available across India. Some states it is easily available, some states it is very difficult. There were even amendment in the NDPS Act, but even then there are problems with accessing opioids. So in this session, we will understand what are the uh, amendments in NDPS Act. How can we access easily access opioids? How can we overcome the obstacles, etc. Today's session will be taken by Rajagopal sir, and he doesn't need any introduction because he has taken many sessions for you. So, welcome, sir, and it's over to you.
Hello, everybody. Am I audible?
Yes, sir, you are.
This is something of an occasion, isn't it? Last session, swan song. Um, why don't you all give me a smile to start with? Last session. Very good. Thank you. Some people are finding it very difficult to smile, but that's okay. Okay. I am glad you were here for this course. You are all agents of change, and each one of you is going to do a little bit towards lessening the burden of suffering in our country. That is not a small thing. If you take all the sorrow on one side and all the happiness on the other side, each one of us is going to take some of the sorrow from our country, and that means some of the happiness gets added on. Let us not underestimate the importance of what we are here to do. You all have had some sessions on various aspects, including pain management, the ladder, etc., etc. So you know to some extent how to treat pain. There will be still some doubts because you have not had except for some of you, most have not had a practical experience in managing opioids. But those we can overcome with our continued interaction. But you will find as you proceed with your mission of reducing that burden of suffering from our country, you will find that when you ask for morphine, you find eyebrows to be raised. People look at you as if you are a criminal. They never thought you would do something like that. What are you aiming to do? You must expect these reactions. So when you ask for morphine and the hospital superintendent says, "What? Morphine? We don't want it in this hospital." Or the pharmacist, after all that, says, "I am not going to take care of that. No way. This is risky. I don't want to be part of it." Will you accept defeat and go back to what you were doing till 2 months back? Or will you do something about it? This is what we are going to talk about. We do have a difficult situation in the country. Sunil already mentioned that. Maybe 2% or at the most 4% of people have access to pain relief in our country. So we do have a lot of work to do. And the nature of the problem is what we are going to talk about. To assist me in that process, I am sharing this screen with you. And I would like you to look at this picture that I am showing. The image shows what happened in 1986 with the introduction of the WHO ladder. It's only 1986. No, I know when some of you were born after that, but the concept of pain relief, especially in cancer, was there even earlier, but came into wide acceptance only in 1986 with the introduction of the WHO pain ladder as we know it today. And from that time, look at that bar chart. This is the way the consumption of morphine rose till the end of that century, steadily upward. But look at what happened within our country in the same period of time. 1985, this happened. It started falling. We were doing exactly the opposite of what the rest of the world did. The reason is something that we will understand so that we can look for a solution. Okay, everybody? This was the reason for the problem that occurred in 1985. From the 1960s, there was this global recognition of addiction as a problem. And a 1962 convention called International Single Convention called for all countries to legislate to prevent addiction and abuse of opioids. India did not do anything in the right time at that time. We were early in the stage of our independence. It was only 15 years since our independence. We took some time. And when they gave the International Convention gave an ultimatum in 1985, this was put together. Look at the size of that book. The laws and rules governing opioids. This amendment was the reason why, while the rest of the world went on increasing opioid consumption, India started reducing it. It took 19 years for the palliative care activists in this country, but eventually we have got it changed. But this is something that I would like request everybody to accept. The 27 or something participants in this group, I am hoping that each one of us will accept this dual responsibility. We certainly do not want the opioids in your institution to be diverted to the streets. It is true that oral morphine is not very addictive, but if it gets into the wrong hands, it will be dangerous. But we also need to make opioids available for those in pain. That means, ladies and gentlemen, you are no longer free to say, oh, the medical superintendent is not allowing it. The pharmacist is not allowing it. No, if they say that, we will have to strategize. Sunil and I and Rajalakshmi and everybody in Pallium will be with you. We will assess why is the medical superintendent objecting? Why is the pharmacist objecting? We will find a way of overcoming those problems. So that's my first request to you. Please accept this responsibility. You are not only a doctor, you are also a human being. That's our generic name. We are also human beings. We are citizens of this country. I think on another day I told you about Atul Gawande's concept of the citizen doctor. We are citizens, and so rather than just prescribing and prescribing medicines, we will accept this responsibility to make opioids available for those in pain, because if you accept that mission of reducing the burden of suffering in our country, you will have to accept this responsibility. I am waiting for some reactions from the audience at this stage about accepting this dual responsibility. I have reduced the slideshow only to see any chats that may come in. Or shall I keep it on slideshow, and Raju or Sunil, will you call out if there are chat responses? The question is simple. Please, ladies and gentlemen, accept this responsibility. Will you? That's my question.
Dr. Savera Ahmed says yes. Dr. Chedana Agarwal, yes. Dr. Sandeep Kumar says yes.
Oh, I mean, thank you everybody who says yes. But if somebody is hesitating, now I want you to explain why you are hesitating. Is it that your job is such that you don't have the freedom to speak out? You don't have the freedom to advocate? Or you are afraid of something else? Anyway.
Sir, can I say something?
Yeah.
It is Vandana. And
yes, Vandana.
I just want to let you know that in Bihar, we live in Motihari district. It's near Indo-Nepal border. And what I know of is the palliative care was provided in Patna in IGMS, I think, yes. And we never had morphine in our area. But because of the course that we did the last 2-3 months, and I could advocate for morphine tablets. We have a narcotic license, and I work in the community health development department. So we could, like, one more thing. When we asked the cancer data, the district just showed only one cancer patient, and we had in our field more than 100 patients at that point of time when we were looking at the data. And so now I really want to thank the Pallium, the cause and Pallium India and you, sir, and all the participants, that we recently have now got the morphine tablets with us, and now it is in our store, and we have started dispensing the morphine tablets. So this is a great achievement for us. I'm part of a EHA hospitals. There are other EHA hospitals which has, but we never had morphine tablets before this. So I could understand the whole concept of morphine, and also though we were having palliative care project, but we never had access to morphine. So I am so happy for that. And also I'm going to train the my local social workers who are working in palliative care, how to the whole chapter on evaluation and management of pain. And the medical director has asked me to actually to be more proactive in dispensing of morphine. So in a way, I will also be now dealing with more of these kinds. So so I was looking at the primer, that the book that was sent to us. So thank you. So I just wanted to encourage myself and others that I'm really glad that morphine has arrived for the first time in our area, and which is not only going to help our patients, but it also going to help patients nearby Motihari. And also because there is I got a call from Tata Institute from Mumbai, sir, and that they had given our number. So this patient this son whose father is having cancer, he lives in Muzaffarpur, quite far from our place, but he could contact us and we could chat. And even from Kishangarh, which is about 12 hours from here. So we told not to come this far, but now because now more centers will be there for giving morphine. So this is something a very good start for us. So even after doing this course, that's just the advocacy for morphine tablets itself has made a lot of impact to our project. So just wanted to share that. Sorry for taking so much of time.
Can I request everybody to unmute their microphones for a second? And put your hands together for Vandana.
Thank you. Thank you, everyone.
Please feel free to mute yourself if you like. Vandana, my only request to you is, you are an agent of change. You are a change maker. But don't walk alone.
Yes, sir.
Allow us and your companions in this group to walk with you, because sometimes, especially in the early years, this can be a lonely walk, and you may get rather browbeaten at times. Sandeep, you had a bad experience. I know we don't have a lot of time, and Raju is already giving me angry looks, but will you take just 2 minutes and tell us what your experience was?
Yes, sir. Well, obviously, after learning from the first introductory course of COVID-19 and use morphine as a anxious relieving drug and respiratory efforts. So I started using it, and I used for 2 milligrams, and I could see uh, the reaction on paramedical doctors why I'm using it. And whereas on the patient, it was really satisfying, they were more calmer, and the respiratory efforts were done. And everybody from nurses to the doctor, they were cribbing. Are you going to make them respiratory going to come easily? Their respiratory rate was 35 and 40 above. But whenever I had used it, because it was my shift going on, patient was comfortable. There was nothing, even a single drop in oxygen saturation. Respiratory rate by 3 to 5 respirate per minute has gone down. No drop in BP. And at one point, which I got a feedback later because the shift were coming every 2 or 3 days, the patient was asking for me, get me the doctor, I could able to breathe that. And what amount of morphine I had given? Just 2 milligram. But the rest of the, I would say, ignorant healthcare workers, inclusive of internists, anesthetists practicing many years, in spite of showing that the literature, it is very validated drug used in COPD, you use in ACS, you used in sickle cell crisis, you use in pulmonary edema, and put forward the rationale behind them, that why you use morphine. After that, they just kept quiet. They didn't push me to the corner, but their eyebrows were really risen, and I was put to a scrutiny, which I tried to overcome with my literature and the learning from your side, sir. But yes, the change is difficult. You can't change people overnight. We have to work collectively. Thank you, sir.
Savera has written, I feel the same, and even had a few reservations about morphine use before joining the course. So, Sandeep, you and I were in the same position. I myself have treated people with burns and not given them enough pain relief. I feel guilty even today. So, but these people are well meaning people, not our enemies, but they need to be changed. Friends, the first time when I was a professor of anesthesia in the 1990s, by about 1994, I went to the drug controller personally for inclusion of oral morphine. We had only injectable morphine. He was he was a very upright person, and he was insulting. He later told my friend that these anesthetists take money from poor patients for giving anesthesia, and as if that's not enough, They want to become drug peddlers. It was very insulting. I didn't quarrel with him. But let me tell you, 1997, with me sitting before him, the trained drug controller took up his phone, called a manufacturer of morphine in Kerala, injectable morphine, and asked, "Hey, can you make oral morphine also tablets?" And the person at the other side said yes. And this man said on the phone, "I will send you the license this week itself. Please send a request." And he made sure that we have low uh, oral morphine available. Sandeep, you had a
Yes, sir.
difficult time, and I put my hands together again for you. What you did, your persistence was remarkable. And I would request one thing of you, just write down your experience. Don't wait to make a detailed report of 5 pages, something of 1 page. I saw a request from the Lancet for experiences relating to COVID. I don't know the last date, we can check. But even if they don't publish it, this needs to be come out elsewhere. Please write it up. Don't
Sure, sir.
don't blame the associates. Don't name them. But these were the colleagues' fears that we can say. And what you found on the patient, how the patient asked for you. Those are things that we want it on the record. Raju, let us hound Sandeep. He's a very busy man, but we'll work with him to get this report from him out into some journal. Okay,
Sir,
let me move on. Yes,
sir,
please.
half a second, sir. I'm
Yes.
not busy. You are a lighthouse for me, and the Palim India is lighthouse for me in the turbulent sea. And I will for sure put down this my experience. I'm not angry with my colleagues. It's about our medical ignorance and phobia keeping us at abeyance from using this drug. So I will definitely share this with all of you, sir, especially you, sir.
Very, very good. Excellent. Thank you. Thank you. And Kanmani, yes, it is difficult to get morphine. No doubt. But Kanmani, why does it have to be easy? Most worthwhile things in the world are not easy. All the easy things were done by somebody else. Some things are difficult. But that is not a reason for not doing it. But remember, when it is difficult, you achieve it and you find that your life becomes more meaningful. Kanmani, we are going to work together on that.
Oh, thank you, sir.
Anupam, Anupam has written to say that usually pharmacy mandates these logistics. Great. If they will continue to do it, that's fantastic. But Anupam, if in the month of February, the pharmacy comes and tells you, sorry, we have run out of morphine, interruption in supply, you shouldn't be crying with the patients in the OP. You should find out why this happens, why the interruptions are taking place. Take Sandeep's example. You are not going to point fingers and blame people. Instead, we are going to find the bottlenecks and correct them. So we will now learn a little bit about the usual bottlenecks and problems. And
Sir, there is one more
yeah,
comment.
yes.
Currently, physicians need to be associated with an institute to prescribe morphine. How can private practitioners get access to morphine?
Who is it from?
Dr. B.G. Nanda.
Dr. Biji, we will communicate about that. And at the end of the session, during the discussion, Sunil, let us go on to this point of how individuals can hold morphine. We will come to that.
Thank you, sir.
That is not part of my presentation, so Raju, Sunil, one of you must remind me to go back to this at the end. Hey, okay. Now that we have all accepted that responsibility, let us understand this argument which Sandeep and every one of us needs to educate our fellow professionals. All opioid dependence is not addiction. If I have, say, I was talking about burns earlier, so suppose I have burns, it will take many months to heal if it is extensive, and you are treating me with injectable opioids. After a few weeks, I'll get dependent on morphine. You withdraw it suddenly and see the first panel, all these things will happen. Low energy, sleepiness, disorientation and delirium, just like opioid toxicity. Myoclonus like opioid toxicity. And abdominal cramps, severe abdominal cramps and pain, diarrhea. All these will happen if you withdraw it all of a sudden. Ladies and gentlemen, that is not addiction. Physical withdrawal symptoms are not addiction. That is physical dependence. It is only since the turn of the century, or at least till the 1990s, that our scientific knowledge evolved to this level. Otherwise, we used to club them all together. Even now, if you look up a psychiatry book for addiction, you may find that they are all clubbed together. So I repeat, physical dependence is not addiction. If you give somebody morphine for a long period of time, physical dependence will happen. These symptoms will happen on withdrawal. Therefore, withdrawal of opioids, especially when the use has been more than 3 weeks, has to be gradual. Oh, no, not especially. Only when it is more than 3 weeks, has to be gradual. Okay. Addiction is different. Addiction manifests as craving for morphine. Addiction manifests as increasing dose requirements. The person who has got addicted will not be happy with the same dose next week. He'll want more. His body and his mind are asking for more. His mind more than the body. And he will want more and more. And you give them morphine for 2 weeks, and they'll come back and say, after 1 week, I have finished it. Please give me some more. And along with that, there will be behavioral changes. Personality changes will occur. The loving father doesn't care for the family anymore. The loving son abuses his father because their mind is now controlled by the chemical dependence. With oral morphine, it's rare. Repeatedly, we have withdrawn people from oral morphine, but it is possible. Ladies and gentlemen, something that we now know, we did not know earlier, is that addiction has a genetic predisposition. In this group, there must be many people, at least some people, who had been smokers. As a student like me, I thought cigarette made me big and manly, so I started smoking. Many people started. Some people give up without any problem. Some people find it very difficult and cannot give up. Possibly that as a genetic predisposition. With nicotine, the addiction is milder, but with something like an opioid, it can be severe. So, even with oral morphine, if it is that among the minority of people with a genetic predisposition, Even oral morphine may cause addiction. It is rare, but it may happen. But this does not become a problem with cancer because in cancer, the pain is self limiting. Either there is cure or death. Whereas if you give morphine for somebody with a low back pain, alag baat hai, then it is possibly for lifetime. Those are the people who are likely to get addicted. So, one couple of learning points from this slide. Physical dependence and addiction are separate. Addiction manifests as craving for the substance, increasing dose requirement, unsanctioned dose escalations, and behavioral changes, which are rare with oral morphine but possible. And if you use oral morphine for long periods of time in non-cancer problems, Sandeep used it for for a non-cancer problem, but that is short term. But if you use it for long periods of time in non-cancer problems, there is a possibility you have to use it with precautions. It should not be used as a first line treatment in non-cancer pains. Is there any question about any other issues that I have asked in here? Any question about any of the points that I just brought up in this slide? Sandeep, yes. Alcoholism, yes. But because the father has a genetic predisposition to alcoholism, the children may not have the genetic predisposition because the children's genetic structure comes out of the father and mother. It's not necessarily sex-linked transmission. That's understandable. Secondly, unlike many other addiction problems, the addiction and genetic predisposition in opioids is not very clearly understood. So our knowledge there is incomplete. Okay, let me move on. Now, just to show that this is doable, in Kerala, during like this was only 6 years following our getting uninterrupted oral morphine. During a 2-year period, we studied all the patients. This was when I was in Calicut. All the patients who were given morphine, every one of them was followed up. We insisted on documentation. If in the stock book 20 tablets were missing, we explored and found out why. Minor discrepancies were investigated, and we found that we could use it for 2 years without a single case of misuse or diversion. I am giving that link because some people may tell you, hey, ये सब UK में होता है. This is not possible in India. And you should be able to tell them, we don't want addiction either. We know how to do it without risk. We know how to document and follow up. We can use it. This has been studied in the country, proved in our own country. So, our efforts to improve opioid access have been going on since 1995, and it's still going on after a quarter of a century. These were the things that we used, each one of you. I requested Sandeep to write down the story. These stories help. When stories go out in journals, media, social media, they get seen. Every little bit of information helps. In 1998, a doctor No, a pharmacy doctor, a pharmacy in Delhi went to Delhi High Court asking, my mother has cancer. She is not getting morphine. She should have it. She was not in pain, but he wanted it in reserve. That created a government order in 1998. In 2006, 2007, we went to the Supreme Court. The litigation took 6 years, but that also helps. As Sandeep says, we need facts and figures. Somebody says COVID respiratory depression can't give. You should be able to show them the international recommendations. And we should promote the principle of balance. That is, what is the principle of balance? Yes, as you say, we should avoid abuse, but we also have a responsibility to make it available. NDPS Amendment Act has made that possible. We can keep the balance and use it rationally. So what eventually happened as a result of our efforts for nearly 19 years was the Parliament amended the Narcotic Drugs and Psychotropic Substances Act of India, brought in changes, which in a summary I will explain to you. For one thing, the amended act accepted the responsibility for the principle of balance in the sense that it was no longer for preventing abuse, the law was also for ensuring medical and scientific use. Secondly, the amended law brought in a class of medicines called essential narcotic drugs. That's not a very scientific term. Narcotic drug is not a scientific term. Narcotic drug means something that puts somebody to sleep. That's not what morphine does. Anyway, that's the name. Currently, 3 of our step 3 opioids, namely morphine, fentanyl, and methadone, are included among ENDs. Okay, this is important for you to remember. Morphine, fentanyl, and methadone are among ENDs. Previously, every state could make its own rules. So states had different rules regarding essential narcotic drugs. Now, the states have lost the power to legislate. Your state assembly cannot pass any rule, any law regarding morphine or fentanyl or methadone. The central government law applies to all states. So, unlike the old rule, where the rules varied from state to state, where you had to go to several agencies, drug controller, excise, director of health services, etc., for the licenses. And when you used to fight, had used to have this problem. I get what is called a possession license. Then I apply for an import permit. Then the manufacturer has to apply for an export permit. Before he gets it, my import permit has expired validity or my possession license has expired validity. All these things are overcome now. The same rules apply to the whole country and multiple agencies are no longer needed. I know some of you will still be going to the excise. I'll explain why and why not. But today, by the law of the land, the state drugs controller is the only responsible officer for approving RMIs, recognized medical institutions. Once you have that piece of paper saying that your institution is an RMI, you do not need any more licenses. So, implementation of this act, the amendments, unfortunately has not been uniform. I have not gone in details to the provisions of the rules, but this is not uniform. Many states, though it is 6 years now, are still going by the old rules. So we need to work together to make sure that NDPS amendment is implemented, to ensure that palliative care education happens in medical and nursing colleges, and we need to develop state palliative care policy if possible, so that state itself has some plans to move forward. These are things that we could advocate for. So now for every one of you, if you belong to a hospital or an NGO, I remember the question about the individual practitioner. Wait, if you are associated with a hospital or NGO, you now will get a certificate of training. You apply for approval as a recognized medical institution. We will show you the forms. There is a form in which you have to apply. Actually, two forms, not long ones, short forms. One will be signed by the doctor, one will be signed by the head of the institution. You apply to the drugs controller. The drug controller has a responsibility either to accept it, give you approval, or reject it showing the reason. Rejection has to happen showing a reason within 2 months. If they don't do it, we intervene. You allow us to work with you, we will together overcome the problem. Is there anybody from Uttarakhand in this group? Raju, do you remember?
Yes, sir. There are many members in the group.
No, Uttarakhand, I am mentioning this because this happened in Uttarakhand in 2019. Uttarakhand, the activist, Dr. Aditi Chaturvedi, who is now in Himachal Pradesh, and friends went and met all the officials, drug controller, everybody. They all said okay. But when they apply, they will not get the RMI status. Instead, they will get all sorts of vague things. Finally, they said, give us a floor plan of your building. Show us your registration by, what's that? I forget the rule, something. Now, these are not legally required. This was done by some junior officials in the department. So what I did was, I got the permission from the institution. Please permit me to the right to the drug controller. They were hesitant because they were afraid that the drug controller will be angry. But they consented because they had no other way. I wrote to the drug controller. I said, I am writing as the director of a WHO collaborating center. Obviously, there is a misunderstanding. Your office has asked for a floor plan of the building and some other registration. These are against the law of the land. Here is the law as it stands now. These should not be asked for. The institution should have got the RMI approval within 2 months. Please do the needful. I sent this letter by registered post. Within a week, the RMI status was approved. Every government may not do it. Sometimes it can be very hard. But at every step, we will not go and with a bow and arrow and start shooting arrows at them. But we'll be firm. We have a mission to do. I am not doing it for me. Sandeep is not doing it for Sandeep. So we will do the right thing for the right reason. We will persist. Try to overcome the problems. Sometimes, most of the time, they will get solved fairly easily. Sometimes it may take a long time. If it comes to the worst, we will go to the state high court. This is how in our institution the register is kept. Raju is going to share the whole PowerPoint with you. So you will have access to this slide. I'm just giving you an example. It has to be fairly neat, because if you have scribbled names which are not readable, then that is inappropriate. You will notice that every patient's name, this is for opening stock, name, the date of dispensation, and the quantity issued are written here. The patient's registration number is included. This is very important. Let us try to avoid mistakes in this. Mistakes can be calamitous. The last column, okay, they started with a certain opening stock. After issuing this quantity, this is a stock left behind. When a new stock is received, it is written in red, received on. That is added on to this list. This is how we keep the stock. Again, our team stands by to assist you, because in the early days, you will have many doubts. And the last part, non-cancer pain, back pain, for example. Some non-cancer pains have to have opioids, like ischemic pain. Somebody with an ischemia, thromboangiitis obliterans, atherosclerotic impending gangrene, they need opioids. But if it is something like a low back pain, you have to be cautious. But when necessary, they will have to be given. This was a child whom we saw. In our first day, we saw a children's clinic, children's palliative care clinic in the government hospital. We found that this 1.5 years old child here had not slept for more than 3 months, not more for more than 15 minutes at a time. The father lost his job. The mother lost her mind. She was actually became a psychiatric patient. Her depression was so profound that she became non-functional, so that this sister had to act as the mother. Everything. She was doing everything. And the father later confided to us that he had actually bought poison, which he planned to give to these three people, mother and children, and then he planned to hang himself. The child got 2.5 milligram of morphine. The child lived and died pain-free in about 3 months. The father is working. Our social worker made sure that he just one phone call to the employer saying, okay, this is what has happened to him. This is why he didn't come for work. Please give his job back, or the family is in such problem. And the man said, of course, I quite understand. Is that job our job? I would say yes. You, the doctor, cannot do it alone, which is why we must have social workers in our team. The sister is back in school and we are supporting the child's education. Without that morphine, none of these things would have been possible. The girl would have never got back to school because the mother would not have got treatment, would not have become a mother again. What the child had was not cancer, it was post-encephalitic muscle spasms. So, in non-cancer pain, but we'll remember, opioid should not be first-line drug, but must be used when necessary. Before using it to a patient with, I usually would not use it in somebody with low back pain, but if I have to, I'll tell them, this is a drug with a chance of addiction. There are these rules. I'll give you so much. If you say that you have exhausted and come back after 3 days and say your medicines are finished, you need more, I will not be able to give it to you. This may happen. Addicts sometimes go and threaten doctors. I will remember that if I had that man's genetic predisposition and I was in the same psychosocial and physical environment, I could also become an addict. I will not give in to him, but I will not be angry with him either. I will still try to help him. I just want you to know that methadone is another inexpensive opioid, a little more difficult to use than morphine. Those who are already using morphine and are familiar with this, I'll strongly encourage you to go to this link. That's the Indian Journal of Palliative Care. The whole issue is on methadone and is available for free download. Please learn about methadone. If you have problems, allow Sunil to help you because he has about 50 times more experience with methadone than I have. But we stand by to help you. In those patients who do not tolerate morphine well, this can be a great boon. As it happens, the consumption of morphine in the country is only very slowly increasing. But we believe that now we are on a steep part of the curve and it will grow faster. Before I wind up, let me tell you of these various bottlenecks. Parliament has passed the legislation, but state governments' implementation is still pending. But even if they do that, remember Sandeep's experience. The professional obstacles will be still powerful. If you, a junior doctor, goes and argues with the head of department, you are likely to be decapitated, mercilessly killed, at least emotionally. We will have to make it gradual, and our whole team is happy to work with you. But concurrently, ladies and gentlemen, public education is necessary. Sometimes doctors say that it causes addiction. We have actually had this experience. The patient saying, Doctor, did you not read the Manorama yesterday? They have said how it can be safely used. Of course, the access has to be easy and affordable. Earlier, who was it? Savera. No, Vandana explained how people had to travel those long distances. Those are problems to be overcome. Patients, when we dispense it, we will have to give enough information to patients. It is not like giving an antihistaminic. And we have to follow patients up so to ensure that they are adhering to the regime. All these, each one of these is necessary if the patient is to get pain relief. So the route to freedom from pain has all these obstacle causes. And I repeat, it may look difficult, it may be difficult, that is not a reason for doing it. You and I have been given this opportunity by Providence to be the agents of change, and we have the duty to change the face of suffering in the country. So, I have given the link there. The forms which need to be filled up uh, are given here in this link. When you have doubts, write to us. In our office, we have an angel by name Preeta who knows all the forms and things inside out. We will help you. If you have a doubt about what should we fill in there, they are asking for the annual consumption of morphine. We will help you to fill that in. Once the drug controller gives you the RMI, we will assist you to find the cheapest manufacturer who can sell it to you, and the hospital can place an order with the supplier. Our responsibility is to ensure documentation. But before I conclude, I have only talked about RMIs. The new law also makes a provision for individual doctors, private practitioners, to hold morphine. I'll stop the screen sharing. Who was it?
Bijli, sir.
Hmm?
Sir Bijli, I asked that question.
Sorry. Bijli. Sorry. Bijli, Bijli, you are a private practitioner operating, seeing patients in your home, or do you have at least a consultation room or office with a name, registered place? If you have a registered clinic, that's enough to become an RMI. You don't need to have a big hospital setup. For morphine, you don't need even to have a pharmacist. But suppose you are not having a registered. Raju, did you want to say something?
No, sir, no.
Okay. If you happen to have as an individual, there is a provision for private practitioners to hold a small quantity of opioids. It will not be a large quantity, but the format is there in the link that I showed you just now. The rules and forms, that's also there. You can apply. Now, I must admit that as palliative care advocates, we do not promote it by and large because abuses are more likely in that area. Whereas an institution is likely to have a better control. Bijli, though I have not talked about it in detail, I am happy to give you more information about it. Do please email us, and for any private practitioners to access it without going through an institution, we will share the relevant information with you.
Thank you, sir.
Sir, good evening, sir. Sir, I am Dr. Krishnaraj. I have one doubt.
Yes, Dr. Krishnaraj.
Sir, if our parents or relatives are having cancer or something and they are in the final stages, so is this the same procedure for holding the morphine, sir?
Dr. Krishnaraj, which state are you from?
Sir, I am from Kerala, Kollam.
You cannot have a stock except what is dispensed to you by a recognized medical institution. If you need it in the family, what you do is to go to the palliative care center at Chinnakada Junction on a Thursday or Tuesday, I think, 2 days a week. Register yourself, get the morphine issued to you. They will give you enough for 2 weeks. Before it's over, you go back to the clinic and get a second filling in the prescription. So you will get it. The patient has to be registered and the institution will dispense it. I don't know if I have answered your question.
Yes, sir.
Yes, okay. Thank you.
Thank you, sir.
About Deepa's question, can dental college and hospital procure it and dispense it? The answer is a resounding yes. MBBS or BDS and training in pain management is adequate for a doctor to be in charge of a recognized medical institution. But by the terms of your registration as a dental surgeon, if you are by yourself, you are authorized to treat only head and neck issues. If somebody has a cancer of pancreas and you want to use it in that dental college, that will not violate the NDPS rules, but it may violate the conditions of your registration. So, if you have a department of oral surgery, maxillofacial surgery, anything, and you run a palliative care clinic for head and neck problems, you can stock it, use it. That Bijli's question is, is there a 2 weeks limit? Bijli, that is not in the law. The law doesn't specify that you can give it only to this amount. The law doesn't specify an amount. But remember our dual duty, principle of balance. Bijli has a duty to make opioids available to Krishnaraj's family. Bijli also has a duty to make sure that a quantity is not siphoned off to the beachside resort for somebody who is addicted to morphine. That is not possible. So we have to set our own rules. You also do not want it to go to the wrong hands. If you give them enough for 6 months, you may find that it goes out to some other market. So what we do is we give for 2 weeks. At the end of the 2 weeks, they come back. We ask them, not necessarily the patient, we allow the family member to come back. We ask them, okay, how many times have this been taken? And if the family member says, I don't know, the patient takes it himself, we'll ask him to pick up the phone and call the patient. We will make sure that the patient is getting by the story. If they are telling lies, we will easily know. But that doesn't happen. It doesn't happen. It's very, 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 very rare for all morphine to be channeled off. But we usually set our own rules of 2 weeks. But then they say, like Krishnaraj says, I am coming from Kollam. That will take 2 hours, even if I can get a good train. So, can you please give it to me for 1 month? We sometimes give it for up to 1 month for people coming from far away.
Thank you, sir.
Okay. So Priyanka is already doing exactly what we are doing. 1 month for people from far away, like people coming from Nagaland. Deepa, Priyanka, like you, we also have set a limit of 1 month.
Any more questions?
One more doubt is there. I'm
Krishnaraj, by the way, let me interrupt and ask you, do you have a problem within your own family?
Yes, sir. My father is having
Please,
hepatocellular carcinoma.
please call me. Raju will give you the number. Please call me after the session, and we'll see what is necessary. As I told you, which part of Kollam are you from?
Sir, Munangutti.
Sorry?
Munangutti, Kadapakada, that side.
Oh, that's not very far off. So I'll connect you to the people at Chinnakada so that your father can get a consultation and get the medicine.
Thanks.
Okay. You were about to ask me something.
Sir, me or any other participant?
Sorry, louder, please.
Sir, my doubt was like, sir told to call sir, right? So I'll call you.
Okay. That was for this personal matter. Okay. I'm sending it by my phone number by chat to you personally.
Okay.
Sir, I have already shared with Dr. Krishnaraj.
Okay. You are much too efficient for me, Raju. To Priyanka, we also sometimes get, not very often, sometimes have this problem that the patient is coming from an adjoining state, south of Tamil Nadu. I have already continued treatment by phone and given the prescription and send medicine by registered post. Sending medicine by registered post is permissible, but by the new regulations of Indian Medical Council, opioids cannot be prescribed on telemedicine. But that's fine. We don't call it telemedicine. We talk over the phone, make an assessment, if necessary, get a local doctor to see the patient and send the medicine across. Can we get a list of all places in India where PC and morphine is available? I don't think such a precise list exists. But Vandana, in our website, Pallium India website, if you look for a directory, you will find it. There is a statewide list of Pallium. No, it's even on the homepage. When you get to Pallium India's website, you go to the homepage, scroll down to the bottom, and you will find two red buttons. One will say donate, the other will say find services. These are not interconnected. You don't have to donate. But find services, click on find services, and then a map will appear. You click on the individual state, and what we know will be available to you. Can I also make a request to everybody? Please visit the site. And if you know of centers where that have morphine and palliative care, and it is not in our list, please let us know. It will help somebody who needs it badly. I am going to Raju, with your permission, I am going to share the screen again, okay?
Yes, sir.
Do you see this? In our home page also, you will find this, find services. You click on this, and this map will appear. And you click on the name of the state, Rajasthan. And all the institutions with opioid availability that we know of will come here. But I accept recent changes we may not know at all. So do please come back to us. Among you, let us include your center also here. Many we are not aware of. So please help us to update this directory. Thank you very much.
Is there any observership available or electives available at Pallium India? That was asked by Dr. Sandeep Kumar.
Raju, why don't you answer the question?
Sir, as such, I didn't get the question. Electives means?
No, Sunil. Sorry, I meant Sunil. Sorry, I said Raju. So, I mean, okay, I will take on a question myself. By all means, Sandeep, certainly. But what I would recommend is, I would recommend to each one of you, these are times of COVID. We don't do physical training. All our online training was upscaled to deal with the crisis, so that because otherwise, as soon as the COVID crisis is over, let's hope that the vaccine becomes available in November and we would not have to worry anymore. At that time, we will start the courses again. We do physical courses, but by all means, we'll encourage everybody to undergo physical training in a good center. We can certainly welcome you at Trivandrum, but for some of you, Sandeep, we are very, very far away. We will also work with our colleagues in North India also, if that's your preference. But Sandeep, we must meet you in Kerala. Do come over, take your family, and after the COVID crisis, have a holiday in the backwaters in Kerala or in one of tourist resorts in Trivandrum. Let them enjoy, and you come and be an observer with us for a few days. Raju, on your behalf also, I am extending a warm welcome to everybody to Trivandrum when the COVID crisis is over.
Yes, sir. Really happy to have all here.
So there is another question. Can we prescribe morphine in dental college? I think
I think I
this was
answered that.
answered. Yeah.
Yeah. Deepa, do you still have a question about that?
Yes, sir. I missed that answer actually, sir.
Okay,
Yes,
okay,
sir.
okay. Chai
Yeah.
पीने गई थी क्या? Deepa, uh, by the law, dental BDS or MBBS is enough qualification to have an RMI, or to stock you morphine or to dispense morphine. So you should apply with your certificate of training and apply for it. But your registration in the dental council mandates you that you are authorized to treat only diseases that are only problems concerning the head and neck. If you treat somebody with a CA pancreas, dental council rules may not allow it. That's only limitation. So you would have a maxillofacial surgery department in your dental college, start a palliative care clinic, treat all those problems. Or if you also have a medical college in the campus, have a joint clinic, that's also fine.
Okay. Thank you, sir. Thank you.
Chetna, most welcome to Trivandrum after the COVID crisis. Hey, who called me Gandhiji? Chetna, this happens to me all the time. I think it's because of the combination of my head and my specs. Uh, I remind people of Mahatma Gandhi. Great privilege. Thank you. Uh, uh, Anupam asks a difficult question. How much to be consulting fees for palliative services? Certain some PLCS. What is private?
Certain places charge high.
Places charge high.
Yeah, yeah.
Hey, listen, Anupam, in our country, there's hardly any control on private medical practice. Actually, there's nothing. Anything goes. So, I'm sorry, this is one cancer question that I cannot answer. We do not charge consulting fees. 82% of our patients are poor. When rich people come and ask what is the fee, I'll tell you my standard answer. Oh, we don't have a billing system, but we hope that those who can afford to pay pays what would be a consultation fee elsewhere, and also twice that much so that we can treat on more patients. So we are good at begging. At least I am. Some of my colleagues still are not good at it. I ask for money and ask for donations. So I don't know the answer to your question, Anupam. I don't know what is correct, but I see no reason why the consulting fee will have to be different for palliative care services than for any other healthcare service.
I just talked to a person at corporate hospital today, and he told his consultation fee is 1,700.
Again, there's a caste system amongst private hospitals, right? There are the upper caste private hospitals where they charge most. Then the smaller the building, the less the private consultation fee. That is the law, the rule, usual rule.
Are there any more questions?
Thank you, Chetana. Okay, Anupam paid 1,500. Anupam, I'll tell you, we have actually calculated the cost of a home visit to our unit. That includes the salary of the doctor, the nurse, the driver. Now, sometimes a social worker also. Now, one team sees an average of 6 to 7 patients in a day. With our roads and traffic, that's all that is possible. So if you take the salary of these 3 people for a day and divide it up by 6 or 7, add the cost of the vehicle, the petrol, all together, I don't think 1,500 is, I mean, it does cost like that. If it is a doctor nurse team with a driver making a home visit, an average expense will be close to that. That's our experience. I think the Sunil, I don't remember. I think the last time we worked out the approximate cost, that was some 3 years back. At that time, we found that our cost to our institution was about 1,200 per home visit. Sorry, Sunil, you have only 15 minutes more for the feedback.
Yeah. So, uh, so now it's your time to speak about this course and give us some feedback by which we can improve our course for the next coming batch. So I would encourage all of you to speak a few sentences and give us something which we should